So good morning, friends. Welcome to the fourth session of the ECG quiz. I'm sure that you are enjoying these quiz sessions and are answering all the questions correctly. Let us get on with today's quiz. Now today I have lined up 3 ECGs for you, 2 12-lead and 1 arrhythmia. So be ready with your pen and paper and answer the questions which I ask. Now this ECG, which was sent to me by Dr. Priya of the nephrology department in the Baby Memorial Hospital, Calicut, is the ECG of a 68-year-old male who came with chest pain and sweating to the emergency and was admitted to the cardiac ICU. Now my questions are, first, what are the changes which you notice in this 12-lead ECG? Secondly, can you tell from this ECG whether this patient had any chronic symptoms previous to his symptoms of today? If you say so, let me know why you said that. And third would be, what would be your preferred line of management in this patient? So friends, I will give you about 2 minutes and you can start answering the question. Okay, so we'll go on to the answers to this question. Let us start with the limb leads first. Now, from this you can find out that the patient is in sinus rhythm with a regular heart rate which works around to around 84 per minute. Now, if you look carefully in lead V1 here, you can see that the P wave shows a negative deflection which is 1 millimeter wide, indicating a left atrial enlargement, isn't it? The PR interval is normal. Now the leads 2, 3 and AVF show Q waves followed by normal ST segment and upright T waves. So this indicates an old inferior wall myocardial infarction. Now let us turn to the chest leads. Look at the chest leads. The QR pattern is there in lead V1, V2, V3 and V4, isn't it? QR pattern. Furthermore, if you look carefully, the ST segment is elevated with upright T waves and the ST segment has a concavity upwards. All these indicate that the patient has a right bundle branch block because of the QR pattern in V1 and along with a hyperacute anterior wall myocardial infarction. This is shown by the ST elevation and the T being upright. It is not inverted yet. And the ST is also not coved. It is concave upwards. Now, This enlarged left atrium shows that the diastolic pressure in the left ventricle would be high in this patient, and hence the patient would have been getting dyspnea on exertion. That was the question about his symptoms before he came to the hospital. That is, he would have had dyspnea on exertion because the left atrial pressure, because of the left ventricular diastolic pressure, would have been high. So that is the reason. He could have even had episodes of pulmonary edema. We don't know the past history of this patient. Now the question, last question was, what was the management you would have adopted now? Of course, in a hyperacute myocardial infarction, especially with an old inferior wall infarction also, I would advise an immediate coronary angiography with appropriate angioplasty if possible. For example, if this patient is a diabetic, already had an inferior wall infarction, now has an anterior wall infarction, and if your coronary angiogram shows a surprise like a multivessel disease, then of course it is not the angioplasty which you do. You will be planning for a bypass surgery, coronary bypass surgery. So an immediate necessity for this patient is to have a coronary angiogram. So our diagnosis would be old inferior wall MI, hyperacute anterior wall MI, right ventral branch plaque, and left atrial enlargement. Now we'll go on to the ECG. Now this is one of my very old ECGs taken up perhaps about 40 years ago. That is why it looks a little faded. It is the ECG of a 45-year-old man with exertional angina of 2 months duration. The ECG was taken as soon as he came to the OPD, climbing 2 flights of stairs. The OPD was in the 2nd floor, so he had to climb 2 flights of stairs to come to the OPD, and the ECG was taken as soon as he reached there. And the questions are: 1. What does the ECG show? What are the findings in the ECG? 2nd, what is the QRS axis of this patient? And 3rd question is, what do you think is the cause of this ECG change? So you can start answering this. So friends, we will go to the answers to this slide. So what is the striking feature here? This is the downsloping ST segment you see in many leads, isn't it? It's a downsloping ST depression seen in leads 1, 2, 3, AVF, and from V2 up to V6. So the depression is almost 3 millimeters when measured here in this lead, I have measured it using calipers. It comes to about 3 millimeters from the J point and the T is upright. Now, as the patient had exertional angina and came to the OP climbing staircase of 2 flights of stairs, the ECG possibly shows the changes of inducible ischemia when the patient's ECG was taken. So it is like doing an exercise ECG for the patient. Really, this ECG was the patient with angina. He had chest pain when he came upstairs to the outpatient department. Now this change you will see in a patient while doing a treadmill stress test. This type of ST depression, especially downsloping, you may see in patients when you do a treadmill test if it is positive. Now when the patient takes rest after the test, the ECG becomes normal, right? You may think that this ST depression looks like that of a digoxin effect, isn't it? If you remember in one of our last quizzes, I showed you digoxin effect. This looks almost like that. So how do you distinguish it? That is why I always say to distinguish this clinical circumstances is important. That is why in my initial classes I stressed that an ECG should be interpreted always in the light of clinical symptoms and findings and not alone. If this ECG is given to you alone, you can say, even if you tell me it is digoxin toxicity, I will not contradict you. That is why we give a history for the ECG. It is very important that you always interpret an ECG in light of the clinical history and symptoms of the patient. Okay. Now, what are the types of ST depression you can get? Here you have the classical down-sloping ST depression as seen in this patient. It can be horizontal ST depression where the ST is exactly horizontal as if it has just come down like that from the baseline, or it can be what is called an upsloping ST depression where from the depression it slopes upwards towards the T wave. Now of these, the first two, that is the downsloping and the horizontal, are clinically more important and indicative of an abnormality. Okay. Now I asked you about the QRS axis of this patient. That was next question. What is the QRS axis? If you look carefully, AVL is the one which shows you the biphasic deflection. And lead 1, lead 2, lead 3 are all positive. That means the axis is down towards the right side. So if you add 90 degrees to the AVL axis is normally minus 30. So if you add 90 degrees to minus 30, you will get an answer plus 60 degrees. So the QRS axis of this patient is plus 60 degrees. I hope the points are clear. Now we'll go on to the next ECG. So here downsloping ST depression in multiple leads. This patient, it was angina pectoris. Now this is the rhythm strip of a lead 2 in a 50-year-old smoker who had nausea and vomiting as soon as he got up in the morning. It was of abrupt onset. What is the arrhythmia you see in this patient? What is this arrhythmia? What is the origin of the arrhythmia? Where is it arising from? And what is the etiology of the arrhythmia? That is also equally important. Now, this is lead 2, by the way. Okay. So, you can start answering the question for 3 minutes. So I think you would have answered this. Only 3 complexes are shown, but that is more than enough to diagnose this ECG. We'll go on to the answers. So what do you see here? I'm showing the full ECG. There are more complexes seen in this. That was a little enlarged picture which I showed you. So what you see here is the P waves are all inverted. This is lead 2, I said. P waves are all inverted. This indicates that it is generated from the low atrial part or from the junction. From the lower part of the atrium, it is going upwards into the atrium. The second point is the PR interval is very short. You can look at here. PR almost no PR interval, or you can see just 1 millimeter or less than 1 millimeter. So because the PR interval is short, it is possibly from the junction, right? If it was from the low atrium, there will be a normal PR interval, because from the low atrium it has to enter into the AV node and then pass the junction of his and then it stimulate the ventricle. So it will produce a normal PR interval, maybe a little shorter than the sinus rhythm, but still there will be an adequate PR interval, whereas here the PR interval is ultra short. So that would say that this is more from the junction than from the lower part of the atrium. Now let us concentrate on the QRS complexes. The QRS complexes are narrow, they are regular, isn't it? And the RR interval, which I have already measured for you, this encloses 6 large squares. One large square is 5 millimeters, 6 large squares. And to note the heart rate from this, you divide 300 by 6. When you divide 300 by 6, you will get 50. So the heart rate here is a regular 50 beats per minute. So a narrow QRS complex with inverted P waves close to the QRS just before it indicates what? At a rate of 50 per minute, indicates a junctional rhythm with a retrograde conduction of the P wave to the atria. Am I clear? Junctional rhythm. This is junctional rhythm with a retrograde conduction of the P waves to the atria. Now my next question was, what is the cause of this arrhythmia? Now look carefully. When you get an arrhythmia, I told you, look at other things also. Of course, this would have come with a 12-lead ECG, which would have made the diagnosis very easy if you had looked at lead 3 or AVF. Here I have purposefully given lead 2 because the findings are very minimal and subtle. The ST segment shows an elevation of about 1 millimeter and the T wave is getting inverted, isn't it? This is actually an inferior wall myocardial infarction which is developing, and that was the cause of the arrhythmia. I'm sure it was easy diagnosis for all of you. So with that, we will finish today's. The diagnosis was junctional rhythm with a retrograde conduction of P waves to atria with acute inferior wall myocardial infarction, or due to acute inferior wall myocardial infarction. So friends, we have seen 3 interesting ECGs today. I will meet you with more ECGs in the next class. Meanwhile, put your comments down below or email your queries. Now, 1 or 2 people had put some comments, but I could not understand what they had put. They had just written a couple of letters only. I don't know what it meant. And so please write, when you ask a comment, at least give it in a full sentence so that I understand what you are intending, right? Also share these classes with your friends and colleagues and subscribe to my channel. So long. I will meet you again after a couple of days. Okay. Bye.